Sorry, I've been talking with no mic. Hi, everybody. Good afternoon. I'm Lisa. I'm one of the nurses at Lymphoma Australia. Thank you for joining us for today's educational session, CAR-T, the patient experience. It's been a little while since we've had an update on patients and CAR-T, and with it evolving so rapidly, there have been so many changes even in just the last few years. So the aim of today's session is to update you on the CAR-T availability in Australia, including what subtypes it's currently available for, as well as where and how to access it. Sam will then cover some of the practicalities of getting to and having CAR-T, including the financial considerations and the process itself. Following each of the presentations, there'll be a small amount of time for questions and answers, so please type your questions in the Q&A function at the bottom of your screen. I wanted to start today with a quick video of Kerry about her experience having CAR-T. Kerry is a patient who received CAR-T at the Royal Brisbane and Women's Hospital for Burkitt's lymphoma. So I'll just get this video up for you. Give me 1 minute.
Hi, my name is Kerry, and I last year was diagnosed with Burkitt's lymphoma. Burkitt's lymphoma is a very aggressive lymphoma, and a tumour can double its size in 24 hours. I was admitted to the Princess Alexandra Hospital to receive my chemo, which was called Codox M/IVAC, which is a very extensive chemo regime, and it knocked me for a loop. I didn't know what to expect. I didn't know how to handle it. And not only are you dealing with your own emotions and feelings and mental capacity, but you're trying to help your family and friends cope with it as well. So it is such an emotional roller coaster and a mental roller coaster. And there are some days you just want to curl up and forget the world existed. I was lucky enough that I had a great team at the Princess Alexandra who referred me after the chemo didn't get rid of all the tumours, referred me to the Royal Brisbane Women's and Children's Hospital and for a clinical trial for CAR-T. It's been a great journey. It's a lot easier to deal with than chemo. I've been fortunate enough that I've had no major side effects. I don't have any nausea. I don't have any allergies or anything like that. The only thing I do suffer is chronic fatigue, and an hour's worth of grocery shopping is a 2-hour nap. If I have to get up and clean anything, I might just get a corner of the room done. Mowing is still out of the question still. But no matter how much family, friends and support you have, it's a journey that they can't do for you, and you have to go through it alone. And even though they're there to hold your hand or to come and clean your kitchen, it's still something they can't do for you. And they don't understand the mental anguish, I suppose it is, and the emotional upheaval that going through this really does. It takes a lot of strength, and you've got to be positive for this to work. You've got to show that you want to do this. Now, the CAR-T was very simple. They extracted my T cells, which took a couple of hours. Then 10 days later, I was admitted back into the hospital at the Royal Brisbane, where they reinserted my T cells, which are living in me and are continually destroying any cancer cells. They were hoping that it would send me straight into remission, but that didn't happen. But they are destroying the tumours, and they are slowly disappearing, which is great news. It doesn't mean I'm out of trouble yet, but it does mean that there is hope. I can never have any more chemo. My veins are shot. You have trouble getting a cannula in. I'm still wearing a PICC line. The only other issue I've had is low blood counts and low platelet counts, but hopefully over time they'll build up and I'll feel a lot better. Yeah, there are some days you just can't get out of bed, and that's okay too. You know, you just take it one day at a time and see how you're feeling. I go down to the Royal Brisbane every week to have my PICC line dressing changed and a set of bloods done. And that's all I have to do at the moment. And even that hopefully will stop soon. My next lot of testing is in October, which is a PET scan and a bone marrow test, and to see how the cancer and the tumours are all going, if not gone. You know, so I'm hoping that they're shrinking even further or I go into remission. The CAR T has been a lot easier to handle than the chemo, physically and mentally. I think the scary part is because I am on a clinical trial and I'm the first person in Australia to have Burkitt's, that no one can give me a direct answer to whether it will work or not. And they're not sure how I feel about anything. Like, they ask and they look after me fantastically, but they don't know what responses my body's going to give, and everybody reacts differently. Keep your family and friends close. Enjoy the little things, the bright sunny days, and the hugs from little ones. And remember that there's still life. I mean, I'm being a bit isolated because of COVID and the flu, but once that's through, I want to go out and I want to have fun. I'm not dead yet, and I don't want to be. Thank you. Have a great day.
So thank you, Kerry, for sharing your story. I really feel it's so important for patients to hear from other patients, especially in something like CAR T, where it's still relatively new and patients aren't aware of what to expect. So I really appreciate you for sharing your beautiful story. So from here, I'd like to introduce Dr. Duncan Purtill. So Dr. Purtill is a clinical and laboratory haematologist at Fiona Stanley Hospital in Western Australia. His interests are in stem cell transplantation and cellular therapies, and in promoting the use and application of clinical trials and patient registries in haematological malignancies. He is Director of the Blood and Marrow Transplant Program at Fiona Stanley Hospital and Vice President of Australia and New Zealand Transplantation and Cellular Therapies. So thank you for joining us today, Duncan, and presenting for us.
Thank you, Lisa. Thank you very much for the invitation to come along and attend this webinar. And on my side, it was lovely and inspirational just then to hear and watch Kerry's video and to listen to her experiences as a pioneer, really, in this area of treatment for lymphoma. So I am sharing my screen now. Hopefully that's
beautiful,
visible for you. Thank you.
Perfect.
I'm going to provide an overview of CAR T very briefly, and then focus on what's new in the field as it pertains to Australia. Anyway, I'd like to acknowledge that I'm presenting to you from Noongar land, and acknowledge the past and present traditional owners of this land. And what I hope to cover in the 15 odd minutes ahead is a brief introduction to talk about what products are currently available in Australia. And I mean available not as part of clinical trials, but as part of what we would consider standard care, or at least available for certain indications through the government reimbursement programs. I'll mention some new research about long-term outcomes of patients who've had CAR T for lymphoma. I'll mention some new research about using CAR T for large cell lymphomas earlier on in the course of disease. I'll talk about in general terms about clinical trials that are around in Australia at the moment, and a slide about what products might be becoming available in Australia in the near future. I might mention a few CAR T products that are not used for myeloma, but focusing mainly on myeloma CAR T for this. So what are CAR T? So the CAR T stands for chimeric antigen receptor T cell. And the chimeric bit means that it's a mixture, really, a mixture of different components of a normal T cell receptor that have been forced together by genetic modification to turn into a highly specific, so very targeted, and highly effective, so very, very powerful arm of the immune system. So T cells in general are one of the most, if not the most important arm of the immune system that is in charge of really recognizing the myriad different proteins that viruses, bacteria, fungi, etc., can present to the body, picking them out from all of the body's own various normal proteins and inducing an immune response against it. And interestingly, T cells also are very effective at recognizing proteins from non-bacterial or microbial origins, such as proteins from other people. So in the setting of a stem cell transplant or a transfusion where there are protein differences between the donor and recipient, the T cells will recognize that. And increasingly, we're coming to understand that T cells are really important for preventing the onset of cancer and in providing a sort of surveillance against abnormal self cells that might develop. So that understanding, I think, is what led to the concept of the T cells being harnessed as an anti-cancer type of cell. And on this slide, it's summarizing in the little diagram there the kind of synapse or immune handshake that happens between the CAR T cell and the antigen presenting cell, which is presenting the antigen or the protein from the tumor cell itself. And on the right side with the circle is really just a diagram going into the specifics of what the CAR receptor actually looks like. And the red circle is outlining the fact that we're now using second generation chimeric antigen receptor cells that have not only the blue part, which recognizes the target or the protein in question, but also an additional red and purple part, which is inside the cell, which is there to really enhance the likelihood of the T cell activating the immune system after the blue bit, the receptor, its binding area has bound to the target protein. So it's an elite, highly targeted, very powerful immune cell that has been forced to target a certain protein, and in this case, we're talking about the CD19, which is a protein expressed on all B lymphocyte cells in the body. I think Sam's going to go into the actual process for how these are created in more detail, but broadly, as Kerry mentioned in her video, the person having CAR T cell treatment, first of all, has to have the lymphocytes removed from their blood through a leukapheresis or centrifuge process. The cells then get sent to the third-party laboratory who go through a very complicated, but in some ways amazingly fast when you think of everything that has to be done, process of getting the gene, the gene or the message into the cell to teach it to produce the new receptor, letting it do that receptor production, and then letting it expand until the dose is achieved that's going to be meaningful for the patient. There's a whole lot of quality control checks that happen then before it's returned to the hospital where the patient is in a frozen state to be thawed and then infused immediately. And the person getting the CAR T cells gets some chemotherapy prior. Now, I won't go into this in detail, but just briefly, it's not strong chemotherapy like one would have, for example, before a stem cell transplant, but it's relatively mild chemotherapy aiming to deplete the host or the patient of their normal T cells to allow space, if you like, within the body for these modified T cells to expand. So what's available in Australia? Well, to become available for treatment outside of a clinical trial in Australia, a product needs to go through a regulatory approval, and that's the Therapeutic Goods Administration, or TGA. And all of their outcomes are available online at the TGA website for the different products. Once it's approved, though, doesn't mean that the government will reimburse a product. And in the case of CAR T, that reimbursement recommendation needs to come from the MSAC committee, which is a committee of specialists in medicine, biotechnology, and economics as well, who make a recommendation not only about the utility but about the cost-benefit analysis as well. That recommendation goes mainly to the federal government, and after that, the individual centres in the different states need to be onboarded to start treatment. That's actually quite a big process. It involves agreements from the state health departments to co-fund the product, so only part of the funding comes from the federal government, and it also involves an audit and education process within the centre to make sure that they have the lab and the apheresis collection and the clinical capacity to provide the treatment. So this is the status at the moment for CD19 CAR-T in Australia. So there are the two products, Tisagen Lechlucil, which is made by Novartis, and Axicaptogen Silolucil, which is made by Gilead. They all have very long names, these products. The brand names are a bit easier, Kymriah and Yescarta. So both of those are TGA approved, and both of those have received a positive recommendation from the MSAC for funding within Australia. And that's very specific, and it's funding for people with relapsed large B-cell lymphoma who've had at least 2 prior lines of therapy or attempts at therapy. So in Australia, these are available in Queensland, as you well, some may know, at the Royal Brisbane Women's Hospital. I put in brackets there that Kymriah is also available for children and young adults with acute lymphoblastic leukemia, and for children that's at the Queensland Children's Hospital. New South Wales, RPA Westmead, and at the Sydney Children's Hospital. Victoria at the Peter MacCallum Cancer Centre and Royal Melbourne Hospital, which together form the VCCC, and at the Alfred, and soon the Alfred will have Yescarta available as well. And finally in WA at Fiona Stanley Hospital, where I work. Unfortunately, centres in South Australia, Tasmania, and the territories are not yet on board for delivering CAR-T. So people from those areas need to be and have been referred to one of the other sites. So I mentioned these the MSAC recommendations. So they publish criteria for clinical, boxes that need to be ticked for somebody to be eligible for reimbursed CAR-T. And there are a whole lot of specifics there. And we don't have time, I don't think, to go through those. But like I said, it's large cell lymphoma, so that includes diffuse large B-cell lymphoma. It includes grade 3B follicular lymphoma, a rarer subtype called primary mediastinal large B-cell lymphoma, and transformed follicular lymphoma, which is follicular lymphoma that's changed into large cell lymphoma. So, for example, Burkitt lymphoma is not on that list. It's not available as for commercial treatment in Australia, and that's because it's still been explored as to whether or not CAR-T is effective, and hence Kerry is enrolled in a clinical trial in Brisbane regarding that. There are some specifics that I won't go into on this slide as well. So I mentioned new research. So I guess some new research that was presented recently, which is promising, is long-term follow-up on people who've had CAR-T for the standard indication at the moment, which is lymphoma that's relapsed after 2 prior lines of therapy. And previously we knew that in about 40% of people, it resulted in a remission that lasted, say, at least 3 to 6 months, which we thought was a meaningful remission. But what's pleasing to see is that having followed people who've had CAR-T for 4 years and more now, it seems that the vast majority of those people who achieved a remission and were still in remission by the 6-month mark are still in remission some 4 years later. So that's really promising. And it sort of hints, I guess, at the possibility of that lymphoma being cured once people are in that position. And it compares favorably to the outcomes prior to the availability of CAR-T with the older chemotherapy attempts at achieving remission after 2 previous lines of therapy had failed. And this curve is showing what the previous experience was like. And really that was sitting at about 20% of people remaining free from progression of their lymphoma at several years later. And I've just put in a dotted line of where the 40% for the CAR T would sit now. Now, it's not a proper comparative study. These are what people weren't randomized to get CAR T or chemotherapy here. We're comparing perhaps apples and oranges because they're a whole different bunch of people, but we can infer at least that the outcome long-term is significantly better for people who respond to CAR T. Another part of new research which I'd like to mention is bringing the CAR T treatment earlier in the course for treating high-grade lymphoma. So I mentioned the current availability after 2 prior lines of treatment and relapse after 2 prior lines. These 2 trials presented at the recent hematology meeting were looking at whether or not CAR T was effective at controlling lymphoma at first relapse, so the very first time it comes back, if it does come back. I should hasten to add that in most cases, lymphoma, high-grade lymphoma, does not come back after the first chemotherapy. But it was comparing CAR T to autologous stem cell transplantation, which is the current standard treatment. There were 2 different products, one using Kymriah, which was the Belinda study, and one using Yescarta, which is the Zuma-7 study. This is the primary outcome from the Zuma-7 study, and what the curve is showing in blue is that about 40% of people 2 years after the study started were still in remission from their lymphoma, so no sign of their lymphoma coming back, having been treated with CAR T-cell therapy, but only 16% of people who were treated with the standard chemotherapy and then stem cell transplant were still in remission at that 2-year time point. So a clear advantage there to the CAR T in that situation. But interestingly and unfortunately, the same was not seen for the other product, the Kymriah study, where the outcomes in blue for patients who got Kymriah were very similar to the outcomes of those who got standard stem cell transplant. So a cautionary tale here for us to remember that although the technology sounds really exciting, CAR T is not always the answer, not always better than what else is available. So at the moment, what's happening in Australia? Well, those 2 studies that I mentioned were active in Australia, but they've finished recruiting. Nowadays, in Australia anyway, the clinical trials are looking at, I guess, different forms of that CAR T technology. So another immune cell, which is perhaps less is known about and has been used less for treatment, are natural killer cells. They sound pretty lethal. They're probably not as prominent in the immune system as T cells are, but they can be harnessed as well to target lymphoma. And there are some trials underway, and participating sites are in New South Wales, Queensland, and Victoria using NK cells for lymphoma. Another way to use CAR T is instead of using your one person's own T cells and genetically modifying them, you can use donor T cells from somebody else, who could be, for example, that means that those donor T cells could be harvested, made and sit on the shelf and then be given much sooner to the person without having to wait for creation of T cells from that same person. And those studies are available in New South Wales, Victoria, and up the road here in WA at Charles Gardner Hospital. And finally, locally made CD19 CAR T is available, and that's the study that Kerry mentioned in Brisbane. So moving on, I think this is my final slide to what's next. Well, there are some applications in process for further commercial or standard therapy availability for other CAR T products. There's a product called Tecartus, which is made by Gilead, which is a CD19 CAR T, but it involves a purification step of the harvested blood before the T cells are made. And that might be relevant particularly to mantle cell lymphoma, where sometimes the lymphoma cells can circulate in the blood. And so there's an interest in getting rid of those before you make the CAR T. It looks like it's quite effective in relapsed mantle cell lymphoma. It's received a positive TGA approval. It's actually received a positive funding recommendation from the government. And now we're waiting for centres to go through the process of getting approval from their local state health department and doing the onboarding. The last one is Cilta-cel or cilta-captogen autoleucel. That's a different product against myeloma, which I won't go into, but that's had approval from the TGA, and the MSAC is considering that approval for funding at the moment. So that one we think is on the horizon. Another slide, sorry, I thought I was at my last, but nearly. We sometimes look to the United States to see, well, what might be coming next. So these products have not yet been approved by the TGA in Australia, but they have been approved by the FDA, the Food and Drug Administration in the United States. So they're getting used for people in the United States, to my knowledge, and that's Kymriah in relapsed follicular lymphoma, Yescarta for large B-cell lymphoma at first relapse, and that's the direct result of that study that I showed you earlier. And finally, another CD19 CAR T-cell product from a third company is available in the United States for treating the same lymphoma conditions as we have the other two products for here in Australia. So that's a summary of what we've covered. We've talked about the two main CAR T products. I haven't gone into the details of what's involved with them, but they are two different products. They're basically available at the moment for similar indications in terms of lymphoma anyway. They're available in those states. Remissions with CAR T in lymphoma, when they happen, seem to last a long time, and that's really positive news, and we look forward to following that in the research sphere. Yescarta does seem to be effective, and more effective than a stem cell transplant when used early in relapse, and we wonder whether that's going to become available in Australia soon. There are other studies looking at different types of cells and putting that CAR receptor into them in Australia. And there are likely to be some new products in CAR T available for mantle cell lymphoma and for myeloma in the near future, talking about the next 12 months. So that's the end of my presentation. I think I've gone a little bit over time, apologies, and I'll be very happy to answer any questions.
So I think, Duncan, there's been a question from Amy online who's asked about marginal zone lymphoma, and could these patients be eligible in the future?
Good question, Amy. I think there's a possibility that they could, but I don't think it's going to be the near future because, to my knowledge, for example, well, certainly there's no product that's gone through the TGA process yet in Australia, and the follicular lymphoma approval in the United States is really just for follicular lymphoma, which, although it's the one that's closest related to marginal zone lymphoma, is not marginal zone lymphoma. So I think we're still waiting for the research to come through to fully support that, and then for those approval processes to start up. But
and I suppose that would where they come in through the clinical trials, much like the Burkitt's that Kerry has had.
That's right, exactly, yes. So and the clinical trials do take time, and then that process for approval starts up after they present their results. Yeah.
Now, you did mention in your session that obviously there's no CAR T available in Tasmania, South Australia, ACT, and Northern Territory, but you did say that those patients can get across to other areas. Is it a difficult process for them to be referred over to these hospitals, or and I don't want patients to feel that they can't access these just because they live in a state that doesn't offer it. Is it an easy process?
I can't say it's quite as easy as living down the road from the hospital that's going to be providing it, obviously, but there are no barriers in terms of our permission to refer patients that I'm aware of. And just as you say, Lisa, nobody should have I guess, feel that they're deprived of any type of treatment in Australia because of where they live. And there are kind of Commonwealth guarantees, I think, around access to treatment. So there's no structural reason why somebody could not access CAR T in another state and be referred. And we've certainly accepted referrals from other states here in WA. And I know that the same goes for Queensland, New South Wales and Victoria. And then I think it comes down to more the logistical issues of travel, which I think Samantha might touch on, but that's not insignificant, but can be surmounted.
Excellent, thank you. I had a patient who emailed some questions beforehand and wanted to know if it was common for patients not to be able to provide enough T cells to be re-engineered.
Yes, well, I would say that's uncommon. Now, we've had that once I can think of on the clinical trial where there were very strict criteria and the T cells just weren't high enough. Outside of clinical trial for the standard treatment, we've not seen anybody with too low T cells to treat. I will say that some forms of chemotherapy seem to result in low T cells that last for some time. And so some people, for example, who've received products like bendamustine have had to wait for longer before their lymphocytes came up high enough to have CAR T harvested.
Yeah. And then the other side of that, so they've got enough cells collected. Do you see it common that they don't have enough re-engineered once they've got them?
It's not common, no. And just chatting before this with Sam, she quoted a sort of less than 10% range, and I would certainly agree with that in terms of what we've seen in WA. It can happen, and it's bitterly disappointing if it does, but it will be a less than 10% likelihood.
So we have a nurse phone that patients can contact, and one of the questions that comes across regularly on a very regular basis is why patients can't be paying for this out of pocket and accessing it privately. Could you just briefly explain that to patients so they have an understanding of that?
Okay. Well, actually, it might depend a little bit on which centre's involved, and it depends a bit on the approval process that the centre has gone through. For example, at my centre, we don't have approval for patients to pay for CAR T out of pocket. And that relates partly to restrictions that are put on us by the State Health Department out of equity. And so you're not allowed to pay for treatment that other people can't get in a public hospital here. But there are other centres where that restriction is not in place. And to my knowledge, it is permissible, for example, to pay for treatment, including CAR T cell therapy, at some of the sites in Victoria. So it might depend a bit on which site.
Interesting. And would that be more international patients or private patients?
No, it can be local patients. It can be. Yeah. I'm not sure if any centres have treated international patients. I suppose in theory that's possible as well.
Okay. And just the side effects comparable to chemo. I know.
I think if we compare it, for example, to a stem cell transplant, it's definitely a gentler process, okay, for sure, because that's very high dose chemotherapy. They're a little bit more difficult to predict, the side effects. So I haven't covered them at all, but cytokine release syndrome and neurological toxicity are important side effects. And although we know that they're most likely to happen in the first week or two of treatment, it's not like chemo where we can almost say to the day when the side effects are going to start. And some people have no side effects at all. So it's harder to predict who's going to get them. I think overall, as Kerry said, most people probably find it an easier process than going through multiple cycles of chemotherapy for lymphoma. But I would add that there are some people who've had a lot of previous treatment and then get CAR T cell therapy, and they end up needing to have, for example, blood transfusions or being neutropenic for some time afterwards. So it's certainly not benign.
Thank you. Sorry, a few more questions in the chat. So someone has said, for a patient coming from South Australia for CAR T, how long would they need to stay in Melbourne for
Well, there are two types of treatment, as I mentioned, and one of the types of treatment involves collecting T cells, freezing them, and then waiting about 6 weeks for the cells to get made. So some people might go over, spend a week in Melbourne, and some people have come to Western Australia from South Australia as well, and then head back again, wait for a couple of months, and then come back to that site for treatment. And typically, once treatment starts, you need to be there for at least a month, staying close to the hospital. Now, the other product, Yescarta, it's a shorter turnaround time to make the cells, and quite commonly, we might ask that somebody stay around while the cells are getting made, because the timing is a bit tighter, and that might be all up a 2-month process then to be staying there. But there is a
And you
requirement.
mentioned sometimes it's a 6-week wait. What in that 6 weeks do you have to do to help that patient get through?
Usually that person then needs to have some chemotherapy to keep the lymphoma under control. It doesn't need to go into remission, so the lymphoma doesn't need to go away, but it just needs to not get, worse, so that somebody is struggling with big lumps or getting sicker. Yeah. So usually there's chemotherapy during that time.
Okay, beautiful. We might just do a couple more. So someone says they have mantle cell, and it's their understanding that MSAC have made recommendations. I think you touched on this from Gilead regarding Tescarda. Has this been approved?
So yes, so the Commonwealth government have approved it and made a positive recommendation. But no sites are yet on board for supplying reimbursed Tecartus. Now, my understanding is that there are some sites that can offer access through, through patient payment, but really, I don't know the cost of it, but it's very high, and so, my expectation, certainly within WA, is that we're waiting on the state government and the local approval processes before we're able to provide that treatment.
Thank you. And someone said that they've read the cognitive neurological impact or side effects. How serious can these be?
They are usually short term, but they can be very serious. And it's probably around about 10% of people who get CAR-T who have serious neurological side effects. But it can be, in its mildest form, it's a slowing down of the thinking and speaking, and someone's handwriting gets more messy. But at its most severe form, people can go really into a coma or even have fits or seizures. Usually those people are cared for in the intensive care unit. And it's very scary for all involved. In fact, least so for the patient themselves, who doesn't remember it afterwards, but certainly for those around them. The good news is that the vast majority of people recover 100% from that. There have been some very few cases where people have not made 100% recovery and struggle with ongoing cognitive or neurological problems. But the vast majority of people have recovered within a month or so of the CAR-T, and usually within less time than that.
And I suppose that's important to highlight too, why it's done in such a specialist centre. So the staff are trained to notice these symptoms quite early, so you can get on and help to try and eliminate them quite early. I know the nurses are very well trained in these centres to pick up on these side effects rather early. So,
absolutely, yeah.
I think that's all of our questions for today, for you, Duncan, so far. I think we can move on. And I really appreciate your time and explaining that to the patients. I know that they would have benefited from it greatly. So thank you.
Thanks very much. Thank you, Lisa.
Okay, so we will now move on to Sam. So Sam is a clinical nurse at the Royal Brisbane. Sorry, I've just lost my notes. So Sam, I'm sorry, Sam, I'm just going to introduce you as I know you. So Sam is a clinical nurse at the Royal Brisbane and Women's Hospital in the CAR-T area. She is been a nurse for, I think, about 12 years from memory. I've worked with Sam for a few years. So, and I'm sorry, I did lose your introduction. That's my problem. But I will keep going. And you can probably introduce yourself, Sam, and Sam's going to talk about the practicalities of it. And I know that there'll be a lot of patients who have some questions afterwards, so you can pop them in the Q&A down the bottom. Thank you, Sam.
Oh, good. Thank you. Can you hear me all right?
Perfectly.
Excellent. I'll just share my screen. So thank you, Erica and Lisa from Lymphoma Australia for having me. It was really lovely to hear Kerry's talk and her experience, and thank you for Duncan as well for that very thorough talk. Firstly, I'd just like to respectfully acknowledge the custodians of the land where our health services are located. We pay our respects to the Aboriginal and Torres Strait Islander elders and valued persons past, present and future. So I might double up a little bit on some things that Duncan covered and some of the questions as well. So I might be able to skip through a little bit faster than what I thought. But I'll basically cover CAR T cell therapy at the Royal Brisbane and Women's Hospital and talk a little bit about the process and some of the logistical considerations. Try and move. Sorry, I can't see my screen completely well. So yeah, just a basic overview of CAR T therapy at the Royal. So we have our 2 commercial products that are available, which Duncan has mentioned. So Kymriah and Yescarta as per their brand names. And you can just see the indications there for both, which I won't go through again. And hopefully, as Duncan mentioned, Tecartus will be coming in the next short while for mantle cell lymphoma. And we've got a couple of clinical trials running. One is a CAR NK cell, and that's for B-cell non-Hodgkin's lymphoma, and also CAR-T1, which is for relapsed refractory CD19 positive B-cell malignancies, and CARTITUDE-5, but that one's for multiple myeloma, so I won't really cover that. So just a little bit of a background about what a CAR T cell is. So T cells are a type of white blood cell. They target and remove bacteria, viruses, and cancerous cells. However, in some cases, cancerous cells have ways of hiding from the T cells. So a CAR T cell is a genetically modified T cell, and that modification enables them to produce a chimeric antigen receptor, or what we call CARs, on their surface. And this enables them to bind and attack to cancerous cells in your body. So it's using your immune system to combat the cancer. This is a bit of a flow of our process, and I'll go through each step in a little bit more detail, but it first starts off with us receiving a referral. And if that patient meets eligibility and is suitable to proceed to CAR T therapy, we'll then collect their lymphocytes. Those lymphocytes are then sent to be manufactured. And at the moment, our 2 commercial products are sent overseas to America. The cells are then made into their CAR T cells and delivered back to us, at which time we get the patient in for their infusion, which is preceded by some lymphodepleting chemotherapy. And after they receive their cells, they're then monitored very closely. And if they've had good response, they'll go into our long-term follow-up. So just looking at those steps a little bit more closely. So CAR T therapy is strictly regulated in Australia by the Therapeutic Goods Administration. And that means it's a high-risk product, and it also has the highest level of governance and clinical oversight. So as Duncan already mentioned, there's only a few centres in Australia that do that, and they're just mapped on there by the stars. So you can see we're the only centre currently in Queensland that do CAR T therapy, and that means we receive referrals from all over Queensland and also interstate, so especially Northern Territory and Northern New South Wales. And during COVID, we also received referrals from South Australia and a couple from Tasmania. We've also received referrals from interstate if the person's carer is in Queensland. So once we receive that referral, we get the patient booked into our CAR T clinic, which is run every Wednesday afternoon. And it's at this point, the CAR T coordinators, they contact the patient and let them know of the referral being received and the booking. And we do just give them a heads up that there's going to be a carer requirement for a length of time. So at least 8 weeks. And they'll also, if they're not local, have to spend a period of time in Brisbane. So once that person's seen the doctor in the CAR T new case clinic, their case is then discussed at a couple of our multidisciplinary meetings. So at the Lymphoma MDT and also our Queensland CAR, our state MDT. And that is to determine if the person's eligible and suitable to proceed for CAR T therapy. So just touching a little bit on that eligibility again, the Medical Services Advisory Committee is an independent body, and they appraise medical services that are proposed for government funding. So their criteria aims to ensure only suitable patients receive CAR-T therapy. And this is really the Australian MSAT criteria in a nutshell. So it just goes by the diagnosis. So there's certain treatment criteria that you have to meet. So either relapsed after an autologous stem cell transplant or relapsed and refractory to 2 lines of prior systemic therapy. And if it's transformed follicular lymphoma, then that has to be relapsed refractory to at least 2 systemic lines of therapy administered after the disease has transformed. And for all diagnoses, they have to be considered to have manageable or controllable disease throughout that collection and manufacture period, which can be a significant amount of time. They also have to have satisfactory organ function, satisfactory infectious disease status. The disease has to be CD19 positive, and they can't have any uncontrolled CNS disease. So once it's determined that they meet all that criteria, they then proceed to have their lymphocytes collected. The lymphocyte collection is an apheresis procedure. And before we get them in, the patients see the CAR-T coordinators for a workup. And that just involves some education. We get them to do some bloods, an ECG, and a chest X-ray. So the ECG is just checking for any heart conditions. They'll also see our apheresis nurse practitioner or a bone marrow transplant registrar for a medical assessment and to consent them for the procedure. So the procedure itself, it's usually done as an outpatient procedure unless the person has to get a central line put in or they might be unwell, in which case they may be an inpatient, but more often than not, they're an outpatient. We need 2 venous access, and that can either be through the veins, or if they've got poor peripheral access, we'll have to put a central line in. So if it's through veins, we'll take blood from one arm, spin it through a centrifuge, collect the T cells, and return the rest of the blood back to the other arm. There are some side effects for this procedure. So one of them is called citrate toxicity, and that's because we have to anticoagulate the person's blood to stop it clotting while it's in the machine. And that anticoagulant we call citrate. So there are some side effects to that. Fatigue, it can cause low blood pressure, bruising, especially at the sites of the cannulation or the CVAD insertion, changes to normal blood and electrolyte levels. They must have a carer to drive them home and avoid strenuous activity for 24 hours. And the goal of this procedure is to collect a sufficient amount of healthy T cells. So once that's completed, we then send them off for manufacture. And at present, all cells are sent to the USA. So the T cells are genetically engineered and modified once they get to the lab, and that's done by using a lentiviral or retroviral vector, which is an inactivated virus. So this transports the genetic modifications into the T cell, which then enables it to express a chimeric antigen receptor, or CAR. And this CAR targets antigens found on the cancerous cells. So this process can take up to 6 to 8 weeks, and it does depend on the product being used. So both the 2 commercial products we currently use target CD19, which is a protein found on the surface of many B cells, both malignant and normal. And CD19 is not expressed in other cells or tissues. So it's a targeted therapy. Once the cells are manufactured, they're then delivered back to the site. And at this point, when we know they're on their way back, the CAR-T coordinators again get the patient in for another workup. This time it's a little bit more involved. So they do have the same bloods, ECG, chest X-ray, but this time also a PET scan and an echo or gated heart pull scan. They also see a bone marrow transplant registrar, again to medically assess and consent them for the infusion. Prior to the infusion happening, the patient needs to have some lymphodepleting chemotherapy. And the role of this chemo is to make room in the bone marrow for the infused CAR-T cells to grow and multiply. So as Duncan mentioned, it is quite mild. It's usually very well tolerated. And for that reason, the person is usually an outpatient. It's usually a regimen of fludarabine and cyclophosphamide, although there is another drug that can be used. And it we'll go over 3 to 4 days, depending on the protocol used. At this point, you'll also be started on several prophylactic medications to help protect you as your blood counts decrease. So they include an antibiotic, an antiviral, antifungal, and an anti-seizure medication. The patient then has a couple of rest days, and then we admit them the day before their cells are due to be infused. So on the day of infusion, the patient's given some pre-meds, and that's usually Panadol, an antihistamine, and an anti-nausea medication. And that's just to try and prevent them having a reaction to the CAR T cells and the cryopreservant they use when freezing the cells. The cells are thawed at the time of administration and go over about 10 to 15 minutes. And all going well, hospital stay is hopefully about 7 to 10 days. So I think our median stay is about 11 days at the moment. The patient's then monitored very closely. So being an inpatient, 7 to 10 days, they're monitored on the ward by the medical team, the nursing staff, and the allied health team. And these are for the following side effects. So the most common side effect being cytokine release syndrome, or CRS. And that's an acute inflammatory syndrome caused by a large and rapid release of cytokines or immune substances into the blood. And the reaction can range from mild to severe, which we usually grade 1 to 4. And the median onset is about days 2 to 4 and can last about 5 to 7 days. There is a treatment for cytokine release syndrome, and that's called tocilizumab, which is a cytokine blockade. So it works really well at dampening that response. The second most common side effect is immune effector cell-associated neurotoxicity syndrome, or ICANS for short. And that's caused by blood-brain barrier disruption, or encephalopathy. And it does typically present as a headache, is probably the more mild symptoms, but can be progressed to more significant symptoms such as word-finding difficulty, confusion, tremor, and worst case scenario, seizure. So the person's monitored very closely on the ward, and that's by doing a twice daily ICE score. So I've just got a little example of it there on the slide. So they'll be asked, what year, month, day, city it is, and they get so many points. They'll be asked to name 3 objects, and they'll get a point each, so 3 points. Ability to follow commands. They have to write a sentence twice a day. To assess their writing and also checking their attention. Once they're discharged from the ward, that is then the responsibility of the carer. They can also have low blood counts. So the anemia can cause them to become tired. The low platelets, they're more prone to bleeding and bruising. And the low neutrophils make them more susceptible to infection. So infection is also on there as a side effect for obvious reasons. Another one is low levels of gamma globulins in the blood, and this is caused by B-cell aplasia. So if people are getting infections and they do have the low levels of gamma globulins, they might be put on some intravenous immunoglobulin support. Some other side effects, mucositis can be caused by the chemo, but we've not really been experiencing that here at the Royal. Again, it's quite a low dose chemo and usually pretty well tolerated. Some do get some nausea and vomiting. Also some inadequate nutrition from poor oral intake. We've definitely seen the fatigue and sometimes low mood as well. So as I mentioned, the monitoring as an inpatient, that's done by the medical team, the nursing staff, and our allied health team. So if they are getting some of those side effects like poor oral intake, fatigue, we've got the dietitians, the occupational therapists, we've got physio, psychology, the welfare team, and the social work. Once the patient's past that critical stage and they're well, they're then discharged and they're monitored as an outpatient. So they do have to come in at a minimum twice weekly until at least day 30. And it's at day 30 that we do a restaging PET scan and or bone marrow aspirate if needed, and a blood test. So if at that day 30, we're seeing some response, then the person will proceed into some longer term follow-up. So we'll assess again at day plus 100, 6 months, 1 year, 2 years. There is travel and accommodation assistance available for both our commercial products. So Kymriah by Novartis have a MyCAR-T Kymriah patient support program, and Yescarta by Gilead work with Rare Cancers Australia. So both programs provide travel support. So if the person's within Queensland, but they're over 100 kilometres or more than 2 hours by car from the treatment centre, then these programs will cover accommodation for the patient and one carer for a period from the lymphocyte collection through until end of short-term monitoring, so at least 4 weeks post-infusion, and also cover petrol costs if the patient is driven over. If they're interstate, this includes return flights to and from the home state to the treatment centre and airport transfers as well. Both manufacturers require the patient to be eligible to receive the state government travel assistance. And this, each state and territory has its own government scheme that you can apply for, which provides a travel and or accommodation subsidy for those who have to travel for specialist treatment. So each state has different eligibility requirements. So I've just included a few links for each state, which details the differences. If there are any out-of-pocket expenses, then they will be reimbursed. And it's also good to note the Leukemia Foundation also offer a wide range of support services, including but not limited to help accessing financial assistance schemes, accommodation and transport options, but the list goes on. So just a few conclusions. The patients need to meet MSAC criteria to be eligible for CAR-T therapy in Australia. We currently have 2 commercial products available, and the current indications are relapsed refractory diffuse large B-cell lymphoma, primary and mediastinal large B-cell lymphoma, transformed follicular lymphoma, and 3B follicular lymphoma. However, watch this space for more CAR-T products to become available to treat a wider variety of indications, as we saw in Duncan's slide. There are some challenges such as the availability, the access and the cost, also the manufacture time. And unfortunately, they're very rarely and uncommon. Some do fail manufacture, and this could be unable to collect enough T cells or the expansion in the lab hasn't occurred. Also, management of side effects, acute and long-term, is quite complex. And there are some considerations such as care requirement and potentially needing to spend a period of time away from home, so near the specialist treating centre. Otherwise, that's all from me. If you've got any questions.
Thank you so much, Sam. I think that definitely covers probably a lot of the questions that we get from patients. I suppose I wanted to quickly ask you, when you talk about carers, like sometimes patients, when they ring us, they think a carer is just somebody who has to be there at night time to make them dinner or might need some assistance in the shower. Can you just explain what you mean by a carer when they need a carer by their side for being discharged?
Yeah, no, a carer, we do recommend being there 24/7. Although it doesn't have to be one singular person, which can sometimes be quite difficult. People can have a roster of close friends, family who are willing to help. It certainly doesn't have to be one person. But yeah, it's more often than not family.
Full-time carer, and that's what I try to explain to patients when they call. It's not somebody just can come in and go. It is somebody that needs to be with you all the time to make sure if something does go wrong that they can get you to hospital or get in contact with somebody. Yeah. So on to the carer topic again. So do the patient's carers need to be when you're consenting the patient for CAR-T, does the patient's carers need to be there for that process as well, so that they're across an understanding of what's expected of them?
Not so much the consenting, but when at the time points they meet up with the CAR-T coordinators for the education sessions, it's definitely recommended that they're there, because we will run through the assessments and the monitoring and the ICE scores. In saying that, a patient's not discharged from the ward until we know the carer is comfortable doing those assessments at home as well.
Okay. And how's that been affected during COVID? So I know that would have been a difficult task for patients who have had it during COVID and they haven't been able to have their carers in hospital.
Yeah, I think we've still allowed that one support person when needed. Otherwise, we're always contactable by phone to touch base as well. Yeah.
Thank you. Now, I think there's been a couple of questions. So compared to stem cell transplant, does CAR-T require less inpatient time and less patient hospitalizations?
Yes, I believe so. So on average, our length of stay for the infusion is 11 to 12 days, which is, I think, a fair bit shorter than a stem cell. We do have a couple that have had to be readmitted for various reasons, potentially infection and things like that, but the rates are a lot lower.
Right. I think we've definitely seen it compared to allos, definitely allogenic transplants and autos. I think their general stays at least 14 to 21 days post day zero.
Yeah.
For cross-border patients, do you have facilities for patients to stay whilst waiting or receiving treatment?
So the accommodation is provided. Waiting, is this even before referrals accepted, or?
I'm assuming that was for patients who come across and then are being collected and then waiting.
Yes. Yeah. So
I think
it's
that's
from
where
time of collection until 4 weeks post-infusion that's covered.
And that's usually through facilities either like Leukemia Foundation houses and I know they're very heavily involved in finding accommodation and getting patients to and from the hospitals. Do you have other accommodation? Do the drug companies sponsor accommodation closer to the hospital for anybody?
Yeah. So there's the Leukemia Foundation, but there's other facilities which we're able to access because of the support programs from the manufacturer. So there's lots of options.
Perfect. Are there any age restrictions on eligibility? Oh, I like that one.
There are, for us in Queensland, this differs from state to state, but we have a 75-year upper age limit. But there's no age limit on a lot of the clinical trials, but commercially, 75 is our cutoff. And just with the carer requirement as well, that can differ from state to state. So our recommendation at the moment is a carer for 8 weeks. And that's with that ICANS side effect. They can't drive for 8 weeks after, and they need that monitoring. So, but I think that can differ from state to state as well.
Beautiful. And I have one more question. So patients who are traveling longer distance, so say someone's coming from North Queensland down to Brisbane to have their CAR-T, with their follow-up, are you in contact with the hospitals closer to them to try and educate them on what to be looking for and how to care for them if they do need to come in emergency situations?
Yeah, so all the patients are sent away with a medical alert card and also a card provided by the manufacturer. So if they did have to present to their local facility unwell, it pretty much says to call our on-call hematologist here at the Royal. So any time of the day. And we're actually also in the process of setting up a website, which they'll have a link to for further information.
Right. And I suppose one other thing I wanted to just comment on, because we get a lot of patients who ask us about this, and it's such a huge process, and it's so there's so much involved in getting them to and from and to collection and then getting to infusion. And they say, but what about the infusion? And then they get slightly, I think sometimes they come away saying the actual infusion was a little bit underwhelming because we've put such an emphasis on it being such a huge process, but the infusion itself, can you just explain that quickly for patients?
It's very anticlimactic. It's about 30 mils in the bag and it goes through in about 10 minutes. So it is, it's really a non-event, and people are often still feeling quite well at that point. You know, the chemo's
Do
not
they
really hit them.
Phenergan?
They do, yeah. They have Panadol, Phenergan, and sometimes an anti-nausea, just to try and prevent them reacting to the cryopreservant.
So often they're possibly even asleep for the infusion, are they?
Yeah, if not drowsy, and then they have a bit of a sleep after. So it's really a non-eventful day.
And it's really I suppose the importance of what then happens afterwards, and it going in and attacking all those cells in the body and trying to make it better. Yeah. So I just wanted to point that out, because patients think it's going to be this huge day and a huge infusion, but unfortunately the actual process itself is only very quick.
The process itself, yeah, it's then that really that critical time after that week after, and monitoring for that CRS and ICANS.
Exactly. All right. Beautiful. Anyway, thank you so much for your time, Sam. I think you have answered a lot of questions that patients have about this experience. And for anyone who's watching, it's recorded, and we will be uploading it to our website for you to be able to access later. So I will do that tomorrow. Duncan's still here. So thank you, Duncan, as well. Did you have any questions or anything?
I didn't know, but no, thanks, Sam. I enjoyed your presentation, and having had the chance to look around your hospital once, I think you've got a great program.
Thank you.
All right. Thank you, everybody, for today. I really appreciate your time. Bye.
Bye-bye. Thank you.